It is now my pleasure to introduce Jonathan Irish. John is the provincial clinical chair of the Cancer Care Program and Quality Initiatives of Ontario Health. He is also the provincial head of surgical oncology program for that program and the clinical lead for the care system. He is the Kevin and Sandra Sullivan Chair in Surgical Oncology at the University of Toronto, as well as serving as the head of the Division of Head and Neck Oncology and Reconstructive Surgery. He is a professor at that program. He is a former past president of the AHNS. And most importantly, John was on our executive committee as all this unfolded. And what was truly important for our organization as we move forward is that we had this mature, experienced voice in the room who could hearken back to what Toronto went through with SARS-1 and really served as a good sentinel for the things that would be coming ahead. And so John has always been wonderful at breaking down problems. And his talk today will really serve as a harbinger of what time will be like. And so to talk about the tsunami after the earthquake, the effects of COVID-19 on cancer services, it's our pleasure to welcome Jonathan Irish. John?
Thanks, Dan. And can you hear me okay? Great. So listen, thanks to you and thanks to Melanie Nance for co-chairing this symposium and our COSM head and neck meeting. I, like May, look forward to the time when we can see each other together. Congratulations to Sherry Ann on her prolonged presidency and for organizing this conference, which obviously incredibly timely, coming together in crisis. And I have nothing to disclose. Thanks to EHAB and May for giving personal and poignant thoughts and reflections on COVID-19. And what I'm going to do is step back, and what I've been asked to do is describe at the system level the effects that COVID-19 pandemic has had on cancer care. The numbers are numbing. You've seen some of them already, but I think it's important that we appreciate the impact, not just now, but in the future. And it's often observed that it's the tsunami after the earthquake that can be more impactful. And if we think of COVID-19 as the earthquake, it's the tsunami that will follow that may be impactful to our cancer patients in particular. And I'll try to emphasize the enormous impact the pandemic has had and the challenges for recovery as we emerge from the apex of the pandemic that are facing our respective healthcare systems. May alluded to history and went back to 1918 and the great Spanish flu of 1918. And pandemics and epidemics are not new to the world. In mid-November 1582, a sailor stepped onto the dock at the port of Alghero, Sardinia, Italy, from Marseille, where he had embarked from across the Mediterranean Sea. The sailor got past the plague guardians, or as they were called then, morbers, and as we may call them today, door screeners or screeners, and whose job it was to stop those who have any symptoms from entering the city. The resulting epidemic killed 60% of the city's population. And the most notorious plague in human history was the Black Death, which swept across Europe and Asia in the 1300s to 1500s, killing an estimated 50 million people worldwide. And it was reportedly present in Paris every 3 years until 1670. And in 1563, it took the lives of a quarter of London's population. But back to Sardinia, and enter a Dr. Quinto Tiberio Angelario, who, having trained abroad, had been exposed to the epidemic and pandemic conditions where he trained, and he saw some of the successes that he was able to employ in his local city. He published a booklet, Actipa Pestilentis Status Allegaria Sardinia, literally a manual for the relief of the contagious disease situation in Alghero. This 432-year-old manual detailed the 57 rules that he had imposed on the city to control the pandemic and epidemic moving forward. Lockdowns were implemented where citizens were advised not to leave their houses or move from one to another. All meetings, dances, and entertainments were canceled. The document stipulated that only one person per household should do the shopping. People were expected to self-isolate for 40 days if a member of their household was suspected of having the plague or being exposed to it. 40 giorni, 40 days. Quarantine, the word quarantine comes from the 40 giorni. So the concept of quarantining, physical distancing, where people who went out in public had to bear with them a cane which was 6 feet long, and it was mandatory that people keep that distance away from each other, avoid shaking hands. Health passports, physical documents which enabled the bearer to pass through the gates, either because they had been certified as plague-free or they happened to know the right people. Lazarettos, or plague hospitals, were set up, and these were separate facilities where active patients could be separated from those either recovering or had other ailments. But let me assure you, since the word Lazaros is the word for beggar, these lazarettos were no 4-star or 5-star hotels. Initially, the measures were extremely unpopular. In fact, the public wanted to lynch him. But as more people died, they came around, and at the end, he was fully entrusted with the task of containing the outbreak. A health services scientist, a doctor, doing his best to protect his fellow citizens. And like over 430 years ago, our public health officials recommended good public health practices all over America. Canada is shown on the left, the United States on the right, and the stringency of the measures being applied being represented by the darker bars on the graph. And the colors don't match, but essentially very similar approaches. We implemented with varying degrees and with varying success control of the pandemic, but ultimately the same measures that were used were very similar to those implemented by Dr. Algarenio 440 years ago. And quite frankly, sometimes with the same reaction. Our public health officials took a hit on both sides of the border. You'll remember this guy on the left, Dr. Staney Brown. He's the dean of our School of Public Health at the University of Toronto and was our previous keynote speaker at the AHNS conference in Washington, and currently is the chair of our COVID-19 scientific advisory table, advising government, politicians on the science of the epidemic. Our governments, our politicians left balancing the risk to citizens and the risk of overwhelming our healthcare services with the socio-economic impact of lockdowns and other measures. Similar position to Drs. Fauci and Birx in your country, and using data and modeling and prediction planning, providing advice to governments on measures that should be taken to protect our respective populations. And they made some tough and informed decisions based on the best evidence that was available at that time. There is no question that mistakes were made and new evidence emerged that adjustments in those recommendations were required. And what I'm going to go over the next few minutes is describe what occurred in our jurisdiction, but it mirrors many others, including many areas in the United States and across the world. And it demonstrates that for cancer care, our challenges are quite frankly just beginning. The tsunami after the earthquake. And what I'm going to talk about for the rest of the lecture is the backlog created in surgery. And by the way, I'm not referring to long waiting lists in surgery. I'm referring to the entire system backlog. The backlog created when primary care physician visits are decreased, when ER visits are decreased, when screening programs are reduced or shut down, OR reductions. And since surgery is usually the first portal of entry into the cancer system, the downstream effects of the impact on surgery and diagnostics, on radiation and systemic therapy services, and ultimately the impact on survival to our patients. And finally, I'm going to reflect on lessons learned and opportunities for improving our respective systems. But if anyone's interested, this paper with regards to the methodology is published in the Canadian Medical Association Journal, and my lecture associated with this, which was given at the Can COVID lecture series, is available on YouTube at that address. And this is the critical waypoints in the COVID-19 timeline in Ontario, in a province of 16 million people in the country of Canada. And the reaction that we had needs to be taken into context. What happened in my province had occurred about 4 weeks after the terrible impact in northern Italy, where the healthcare system had been overwhelmed, and about 3 weeks after the impact in Washington State that May St. John had alluded to, and the terrible experience in New York State, and particularly in New York City, where the impact was approximately 3 weeks in our province after that. Quite frankly, we were scared. And more importantly, we also had a lack of knowledge of the disease. And so on March 15th, 2020, our Chief Medical Officer of Health directed the reduction or discontinuation of elective and non-emergent surgical procedures to create capacity for patients with COVID-19. And this resulted in a precipitous decrease in surgical procedures in our province. And the decisions they made were based on this modeling. The light blue bars shown here represent the Northern Italy experience and translated to the Ontario population. Disaster. It would have overwhelmed our healthcare system. The dark blue bars are the South Korean experience translated to the Ontario population. And very early on, in mid-March, we were trending to be on a curve similar to Northern Italy. And the pink bars shown here demonstrate our actual Ontario experience with implementation of public health measures and all of the things that have been alluded to already by others. We crushed the first wave. The implementation of all those measures was significant. However, it was a monofocused strategy. The results and impact to surgical services in our province was significant. The gray lines in each of these graphs show the historical numbers in 2017, 18, and 19, and the blue line demonstrates the precipitous drop in activity as directed by the Chief Medical Officer of Health for the province. Dramatic decreases in surgical services, even though cancer was prioritized, it reduced significantly, not just because of reduction in volumes, but also because of healthcare hesitancy expressed by our patient population. They stayed home and they did not seek attention. We'll come back to that concept later. But you can see the precipitous decrease in benign elective surgery, including pediatric surgery and some cardiac operations as well. We do about 11,400 surgeries per week in the province of Ontario, about 1,200 cancer operations. So you can see the significant impact in numbers by reducing in percentage-wise the number of cases performed. But basically, we have 19,994 inpatient beds in the province, and within 48 hours, we created 7,000 inpatient beds for the oncoming onslaught of patients. We were waiting for Godot. It was like taking a mass casualty approach for a situation of an epidemic or pandemic. It was like creating capacity for 16 747s that crashed simultaneously. Clearly a lesson moving forward that we need to take, and we did. And here is the next slide, which shows a more detailed view of the effect of cancer surgery, both the precipitous decrease of 37% from March to April, which even though we were informed that we could resume surgical services in May, you could see that even by June, July, and August, our numbers are still lower than expected. And this is in fact a common element seen across all cancer systems. And it's a reflection of, I'll use the word missing patient, quote unquote. It's a concept of the backlog of patients having healthcare hesitancy created by the COVID-19 and not seeking attention with a primary care physician or emergency rooms, and that has impact through the entire system. It's also the concept that healthcare systems can ramp down quickly, but recover more slowly. And this is in graphical terms, looking at all surgical procedures that I've already mentioned, but a picture is worth 1,000 words. And this is all surgical procedures compared to oncology surgery procedures alone. A much more tempered reduction in oncology services, and obviously a more quicker recovery over time. But you can see ramp down quickly, recover slowly. But the concept here is that Canada and the United States are incredibly lucky nations. We have highly integrated cancer systems. So it shouldn't be surprising when one cog in the wheel is impacted, the impact to the entire system can be profound. And that a cog in the system can be from the prevention of cancer with suspension of HPV vaccination programs in our jurisdiction for both young boys and girls, to down regulation or down turning of our screening programs, to patients having healthcare hesitancy and not seeking attention with a primary care physician, and obviously the downturn in imaging, CT, MRI scans, and the impact on the downstream for cancer treatment. This is an example, a slide showing the COVID disruption has affected access to emergency departments and COVID and primary care. You can see the dramatic reductions in primary care visits and ED visits, and obviously demonstrating and really illustrating the impact upstream across our country. And this is reflected in many other countries, including American data as well, which I'll share shortly. Screening programs affected dramatically, not just because they were ramped down with reduction in service because of the directives, but also because of healthcare hesitancy, and this is important. You can see the numbers from reduction in colonoscopy, mammography, colposcopy for gynecological oncology, and high-risk, low-dose CT scan screening for lung cancer. And you can see that we normally do around 27,000 colonoscopies a month, around 60,000 mammographies a month, around 75,000 colposcopies and cervical cytologies a month, and the low-dose CT scan screening around 60,000 a month. And so you can see when you reduce the absolute number in the backlog, starts to increase dramatically. And obviously, when these patients re-enter the system, the tsunami at the after the earthquake effect. The downstream effects are significant, given that surgery is the portal of entry into the cancer system in majority of situations. You can see the downstream impact for systemic therapy in the province and the reduction that occurred, slightly more delayed because it follows the surgical downturn by around 4 weeks. So you can see that the impact wasn't really realized until May and June, while the immediate impact to surgical services was in March and April. And similar, you can see the impact to radiation therapy interventions being down by 28% in May, and still in significant double figures in June and July, showing the downstream impacts and the integration of the cancer system in many jurisdictions. And this just isn't a North American story. In The Economist magazine, and they were reflecting the publication in the British Journal of Surgery, which looked at the first 12 weeks of the pandemic alone, the cancellation of 28 million surgical procedures, and 26 million of these were elective, and 2.3 million of these were cancer surgeries. So the impact for cancellations is highly significant. Some American data that you're well aware of, published in the Clinical Journal of Clinical Oncology, and specifically in Clinical Cancer Informatics. You can see the impact, not dissimilar numbers with regards to March, April, May, and continuing on in a prolonged fashion in June and July, the numbers of mammograms, colon screenings, colonoscopies, lung screenings, and prostate screenings in each of our countries, the impact in the upstream screening, the impact on biopsy shown here on the left, breast biopsies, colon biopsies, and lung biopsies, and on the right, some selective surgical procedures showing similar reductions in numbers with stay-at-home orders or lockdowns or healthcare hesitancy and the so-called missing patient concept, the mastectomy, colectomy, and prostatectomy numbers being down significantly. And finally, in the lower slide, the ambulatory care visits and outpatient visits being reduced significantly. This is work of Kaiser Permanente and the reduction in cervical screening that occurred as a result of probably stay-at-home orders, as well as reduction in services directed by hospital services from 2019, and the comparative in dotted line at the above, and in 2020 below. And you can see, again, the precipitous ramp down and the slow to recovery concept, which I think is an important lesson for healthcare system planners across the world. And this is nice work done by Christine Gurin's group, looking at national trends and specifically now otolaryngology and surgical volumes during the COVID-19 pandemic. And it's a really nice slide. And it obviously takes billing data for 609 hospitals, representing 97% of academic institutions and 160 large community hospitals. And the numbers on figure 1 on the left demonstrates the inpatient otolaryngology case volumes, and on the right, the outpatient otolaryngology case volumes. And you can see from A to G in each of the figures, going through the months from March to September. And the deeper the color, the more significant percentage reduction. So the darker, you can see in March, near normal. You can start to see perhaps some of the effects being seen in New York and Pennsylvania. But by April, you can see the significant reduction in New York and New England states, Texas, and Louisiana being affected. And again, still in May, and again, still a slow recovery over time. You can start to see the Midwest states starting to be reflected, as we saw the Chicago impact in particular, and Minnesota and Wisconsin. And then you can start to see a second wave increase in Texas, Louisiana, Oklahoma, and I guess that would be Arkansas. And you can see the dramatic impact on the COVID-19, both in the initial wave, but also in subsequent waves that follow, both on the inpatient side on the left, and similarly on the outpatient case volume reduction on the right. And then came the second wave. And we crushed the first wave in my jurisdiction. The second wave was a bit more problematic. First of all, it was more significant. We talk about complacency and perhaps COVID fatigue. In my country, most young people returned to school and university in early September. Our Thanksgiving is in October, in early to mid-October, where yours is in November. And the second wave, I think, demonstrates a couple of concepts: the return to school effect, but also the congregation effect that happened at Canadian Thanksgiving when we were no longer in lockdown. And so the impact, obviously, on our COVID inpatient beds, which is shown in the orange slide, and in the ICU admission related, we started to certainly exceed the volumes that were seen in wave one. And although still below our healthcare capacity, obviously we again needed to re-implement public health measures to crush the second wave. And the other lesson we learned, and here is the green, light green is historical volumes. The purple curve describes the actual volumes. You can see that we emerged after June with increasing our surgical volumes over time. And this is all surgical volumes. We still had about a 9% reduction in volumes related to the fact that the patients weren't just not coming in. And so when we were faced with implementing measures around the second wave, we had learned that we don't need to shut down the entire system. We learned, for example, we knew more about the COVID-19 pandemic. We could be, number one, regionally responsive. Ontario is a massive province of 1.1 million square kilometers. It's your average state is about the size of Illinois, and we can fit 8 Illinois in Ontario. So the concept of being much more regionally responsive, so that if there's an uptick of 100 cases today in Toronto, we can be, first of all, regionally responsive. We don't need to shut down healthcare services that are 300 miles away. We also know that we can be reactive. We know that 2 weeks from now, about 10 to 20 of those will need hospital services, and about 2 weeks from now, about 5 of them will need ICU services. So we can be regionally responsive. We can be reactive regionally, and therefore we can be responsible and reflect the pandemic incidents. So we learned a lot, and that was a lesson learned from the initial pandemic experience, rather than taking a mass casualty approach. And now we're in the third wave. And, I can't warn you enough that the third wave is also in the United States. And here's a report from our science table, from Dr. Staney Brown's science table, where our epidemiologists, our scientists, our clinicians advise government. So here is our advice to government. Our public health measures are paying off. We're declining morbidity, mortality, cases, and hospitalization. We had focused vaccination on long-term care facilities, and this was paying off with a real reduction in our elderly, and I'll come back to that as well. Our ICU occupation was flat, but we were starting to see the emergence of the variants of concern, in particular for us, the B117 variant of concern, the so-called UK or Kent variant. And we were starting to see an increase in number, and the demographics of hospital admissions was starting to change. So obviously the aggressive vaccinations, but the fact was that we were starting to predict a third wave at the beginning of March. We were also noticing, and May had alluded to this as well, some mental health indicators well unchanged, were starting to become worsening with regards to opioid deaths and admissions for eating disorders. And so the third wave is upon us, and both in our countries and in many other countries, Brazil included, these are significant numbers. And this is our from last week from our science table. You can see a significant reduction in the non-variant of concern numbers, demonstrated by the purple bars. The purple line is the total numbers, but you can see the orange line and the orange bars reflecting the increase in the variants of a concern. And for us, that's the B117, as it is in your country, and somewhat the Brazilian, so-called Brazilian variant, or the P1 variant. And so for this is from last week, a study of 26,000 patients in Ontario that tested positive for the COVID-19 between February and March. 35% are infected with the variants of concern. It's resulting in a 62% relative increase in hospitalizations, which is being reflected now in all of the jurisdictions. And variants of concern, by the way, have been detected in all 50 states in the United States. It's a 114% increase in ICU admissions, and it is a 40% relative increase in COVID-19 deaths. And it is targeting, or seems to be much more virulent, infective, and is striking a younger patient population. So a meta-analysis published recently, which included the Ontario cohort study, but also the UK and Denmark, demonstrates all of the issues that I've talked about: a higher degree of hospitalization, a double the risk of ICU admission, a 56% increase in deaths. And here is the B117 variant rate that's increasing. You can see in January, 0.1% to the numbers in March 13th of 27.2%. And I haven't been able to update that recently. I couldn't see updated numbers, but the impact of the third wave, I think, is a significant one, particularly as we fight complacency and COVID fatigue. It's basically essentially become a race between the vaccines and the variants. And this is a stark picture. I'm going to now talk about the impact of COVID-19 on our populations, but obviously, in particular, talk about the impact of survival on our cancer patients. And this is a stark picture, but let's recall that it does not tell the whole story. It tells the story of those who died of COVID, but does not tell the story of those who died or will die because of COVID, because of failed screening, because of the failure to present earlier, because of the failure to detect cancer earlier and employ earlier treatment, and the fact that we are seeing much more advanced cancer presentations as patients present. And it doesn't tell the story of mental illness, sudden cardiac death, and all of the other stories that I've alluded to already. This is a slide that Ehab alluded to, both the mortality in the US as well as my country and many others compared to other countries, both because of COVID-19, but the excess all-cause mortality in our countries compared to others as well. And it should be noted that this is from October of 2020, and the country of Brazil, which would now be very clearly represented, is not in that list. In other words, a challenge not just for our COVID patients, but that concept of excess all-cause mortality, which we'll talk about, but was alluded to by both May and Ehab. This is a very provocative, but I think meaningful title to an academic paper, Collateral Damage: The Impact on Outcomes from Cancers from the delay in cancer surgery during the COVID-19 pandemic in the Annals of Oncology. And it talks about the NHS and UK experience of what would result and what, based on modeling, a 3-month delay in surgical treatment would result. 4,471 deaths due to delay and over 87,000 life years lost. Similar papers from my country, and particularly Tim Hanna, looked at the mortality due to cancer treatment delay across the world with a systematic review and meta-analysis, and looked in particular at 7 cancer types, including head and neck, and found a 6 to 8% increase in mortality for every 4-week delay in treatment and surgery specifically, and a 9 to 13% increased risk of death for delay in head and neck radiation treatment. And my colleague, Tony Eskander, an otolaryngologist, a head and neck surgeon, did very similar modeling work characterizing the long-term survival implications of pandemic-related delay to cancer surgery and showing at least a 3 to 5% impact on long-term survival because of the COVID-19 pandemic. And this slide was alluded to by EHAB when we look at excess deaths in the United States from March of 2020 to January of 2021 in a publication reported in JAMA, and a 22% increase in all-cause mortality, and not explained, at least 2/3 of the excess death rates not attributable to COVID-19, but assumed to be from some sudden cardiac deaths, Alzheimer's, mental health, and to some degree cancer. But let's reflect on the fact that cancer patients rarely have sudden deaths, but quite frankly have slow deaths secondary to stage progression. And so, at least for our cancer patients, in my opinion, this story is yet to be written. So what are the lessons learned? Well, May alluded to some of this, but one of the things that we've learned in my jurisdiction, and we have a universal healthcare system, and yet we're still obviously struggling with health inequity. And it's very clear that health inequities were exacerbated by COVID-19. They tend to target, at least in our jurisdiction, multi-generational crowded homes, high immigrant population where English is the second language, service industry workers, warehouse workers, factories and construction sites, and lower income. And this is the province of Ontario shown above, and blown up is Southern Ontario, including Toronto. And you can see the hotspots of COVID-19 infection in my province. And you can see that essentially it would coincide very well to the Ontario neighborhoods where the marginalized patient populations, the high immigrant, lower socioeconomic status, English as a second language, and marginalized populations predominantly reside. It also emphasizes how we can be much more regionally responsive to the effects of the pandemic. You can see there are regions of the province where the incidence of COVID-19 is incredibly low, and there's no need to shut down the entire province at the expense of one region that is challenged with regards to the epidemic. I've already mentioned some of the impact on emergency room visits, and specifically this is a graph showing the reduction in emergency room visits for mental health was disproportionately higher in the younger age groups. And in particular for the 0 to 29, that university-aged students, and you can see the marked reduction in healthcare services for mental health supports, both in the community and through emergency room visits. And maybe related to that is the opioid-related deaths in Ontario spiked after the pandemic with social isolation, and so on, and obviously reduction, presumably, in healthcare services and supportive services to avoid this disturbing curve, and May alluded to this as well. One of the biggest lessons, though, what we learned, and in fact, we learned, I say that in a North American context, is the effect on our elderly, and in particularly those in long-term care. At one point, over 80% of our deaths were in the elderly, in over the age of 80 in long-term care facilities. And that's why initially our targeted vaccination approaches were targeting that patient group. And as we move forward, one of the lessons for us will be to improve services in long-term care, rehab, and other retirement home facilities with regards to nursing quality and social service quality and healthcare in general quality. Other lessons learned, and I'll just take as in the final few slides, talk about the local and regional as well as national or global lessons. And some of these have been alluded to already. Particularly early in the pandemic, the PPE utilization and availability and drug supply reflected supply chain services, not just in our country, but throughout North America, as we have a global market for care and services, and the concept that we need to be more self-sufficient, particularly for critical areas of supply, I think is an underlying lesson for us. I've already mentioned the long-term care facility and impact, the concept that the system is nimble in ramping down quickly, but we recover more slowly. We're spending a good amount of time with public service announcements to return to your family physician or primary care physician with both screening issues as well as healthcare issues in general. And the pandemic is regionally variable and the response must be similar. And I've already alluded to that already. I think nationally and globally, I think some of this has been alluded to already, the collapse of global solidarity. This has been a pandemic that there has been at least initially a communication failure, and which prevented nations from an early intervention to perhaps deaden or flatten the curve even before it started. And that's been alluded to already, and I've already discussed the supply chain impact. I think some of the lessons we've learned is potential of undervaluing science. And I think that's true both in the 1500s when Dr. Algaranio discussed his impact, but certainly the pushback to many of our public health leaders, at least early in the pandemic, was around undervaluing science. And I think that has to be, well, this might be ultimately a success of science over the pandemic. I think that this will be an important lesson moving forward. It has exposed weak public health infrastructures, and I know in both nations there'll be an increased attention to public health and building up that infrastructure over time. The public resistance to risk mitigation measures has been alluded to, and obviously is an important issue. And the early failure of the global health system and a better system of outbreak detection, verification, and reaction. And in the future, we must heed the warnings of future pandemics. We cannot become complacent. What are the opportunities? Well, during the course of the pandemic, I took over as the lead for all of cancer services in the province, not just cancer surgery. So the concepts of the COVID-19 recovery are being sort of put into these three categories, which is easy for me to describe to my other clinical leadership. We're going to restore functionality in areas where the pandemic has adversely affected care and services. We need to sustain positive momentum where we develop new pathways and new structures that were effective in response to the disaster, which will be effective in maintaining continuing care moving forward. And a good example for that might be virtual care. And this is, I think, an example of things that we should continue to maintain, although it looks, based on this JAMA surgery article, that we are low adopters of telehealth services. I certainly think for the follow-up of the thyroid cancer patient, which is largely by ultrasound and blood work, that the potential for employing virtual care where it is equal to inpatient care or in-person care, I think is an important sustained option, or a sustained change that we could continue to carry forward. And finally, transform. Use this event, this unprecedented event, to create new system options or new system opportunities, such as attention to equity of care, to address issues around access to single entry models, central waitlist management, and load sharing, and so on and so forth. But ultimately, this will be a victory of science. In times of unprecedented health disaster, whether it be in the 1300s or today, it has been science that has provided the answers. And it will be up to us as scientific leaders, as clinical leaders, as health system leaders, to continue to lead the way forward in caring for our patients. And ultimately, as alluded to by May St. John, while we are approaching the finish line in this epic race, it will be the advances in medical science, in mRNA vaccines, and the understanding of the power of science to overcome what has obviously been an incredibly impactful event in our human history, is going to carry us forward. So I do thank you for the opportunity of speaking today, and at least sharing my observations from a system leader perspective on the tsunami after the earthquake, the effects of COVID-19 on cancer services. So thanks again.
John, thank you so much for your comprehensive and insightful recap of this pandemic, and also offering a blueprint for the future. Your leadership has been tremendous. We look forward to a time when your curves will cross and our operative and patient visits will exceed our previous year's visits, and we can begin to recap some of the care that we were not able to give. So again, I thank you. Everyone, thank you for a great morning. We have a brief break. Please have a cup of coffee and a cookie on the AHNS. Walk around a little bit, and we'll ask you to join us back at the hour as we begin one of our really outstanding panels that we'll be offering over the next 2 days. Enjoy the break, everybody.